All right, everybody. Thanks so much for sticking around to discuss some more of the kind of policy details and background about site-neutral payments. So again, please, if you're in the room, use the QR code up in the banners if you want to ask a question, or you can text them to 703-527-2734. And we'll be taking those throughout the panel as well. So we have a distinguished panel up here with me today that is truly a bipartisan group of experts that's been working on this issue for a very long time. I'm not going to go through all of the details of your bio. If you're here at this event, you've probably seen all of the details of what they've worked on in the past. But for now, I'll just do a quick rundown of their titles and kind of where they're coming from. To my left, we have Ben Ippolito, who's a senior fellow in economic policy studies at the American Enterprise Institute. We have Lauren Adler, who's a fellow and associate director at the Center on Health Policy at the Brookings Institution. We have Andrea Dukas, who is the vice president of health policy at the Center for American Progress. And we have Joe Albanese, who is the senior policy analyst with Paragon Health Institute. So thanks for joining us, everyone. I do briefly want to acknowledge that there might be some people in the room who just thought it would be fun to hear from some former health secretaries and might not necessarily know what site-neutral payments are. So I'm sure you gathered some of it from the last panel. But to establish a level set here, site-neutral payments are kind of the idea that we want to pay the same price for the same service, regardless of where it's provided. So if it's an X-ray, we should be paying the same amount, whether it's administered in a hospital outpatient department or a doctor's office. Right now, Medicare is paying different prices for these services, and I think we'll get into the nitty-gritty details further down, but just wanted to establish that up front. So I'm just going to give everybody kind of go down the line here and give everybody a chance to just say kind of what part of this debate interested you in working on site neutral. There's a lot of health policy issues to work on. So kind of what sparked your interest? Ben, we can start with you. Go down.
What sparked my interest is a tough question. I'll answer a slightly related question,
sure,
perhaps.
Go ahead. Answer
I do think one of the things that's kind of interesting about this is that one of the reasons that I think you get people from different backgrounds kind of coalescing around this issue is that there are a number of justifications for going down this route. If you're somebody who thinks that the future of healthcare policy in America is a robust, expanded Medicare program, you need that program to function well. You need it to set prices effectively. You need it to not raise costs for no particular reason. If you're somebody like me, where I tend to think that there's value in market forces in healthcare, you want public programs, even if you think in 50 years maybe there's going to be less of a role or more of a role. Today, they're going to exist. You want them to function in a way that tries to at least roughly resemble what a normal market would do. And so I often think about this. If you think about just kind of commodities, if a coffee shop opens up next to Starbucks and offers the same cup of coffee for 50% less than Starbucks, one of two things is going to happen. Either Starbucks is going to meet them at that new price, or everyone is going to go next door and Starbucks is going to close. Either way, the market coalesces around, or they end up at the new lower price. And so that's kind of conceptually the problem here. This payment rule that Medicare has is interrupting that process. And so instead of everyone going to get their drug administered at the physician's office at the cheaper setting, we have this artificial payment structure that maintains this advantage for the hospitals and has this double problem of encouraging hospitals to buy up all of these practices. And so I think it points to this idea of why everybody's kind of gathered here is there's a number of different justifications, and I don't think the current policy really serves almost anybody's long-term goal of whatever you think healthcare ought to be.
Sure, that's fair. I mean, again, I think some of the reason we all probably touch on this issue is we touch on a lot of issues, and this has sort of been a big one that's come up. But I think personally, I've done a lot of work on sort of the corporatization of Medicare and kind of the sort of, moving away from independent physician practices. And this is a pretty asinine policy from that perspective, where Medicare is making effectively an active choice at this point to pay about twice as much on average for the exact same service to be done in a hospital outpatient department rather than a physician's office. And just to give kind of a concrete example here, if you take a physician who wants to go work for a hospital, so that physician is now going to go work for the hospital system, they are going to generate about $140,000 more just that physician from Medicare revenue in a single year. That is a huge incentive. That's also a 2016 number, so that's probably a fair amount higher number today. Right? That is just a very large incentive, both to go work for the hospital system and for the hospital system to start gobbling everyone up. So I'll pass it over to Andrea.
Yeah, I think that's right, and I would echo the final line in the former secretary's joint op-ed, which is that it feels like a no-brainer policy. At Center for American Progress, we're very interested in having a robust, functional, safety net that services Medicare beneficiaries for the years to come. Ideally, that system is even more robust and more generous, and it's important to look for opportunities to pay for that and make that as sustainable as possible. This is I also like the asinine description. It is a very easy, low-hanging fruit opportunity that really derives no benefit. There's no benefit to having these increased payments. Patients lose out, independent practices lose out, taxpayers lose out, beneficiaries lose out. So I'm also very concerned about, without making this fix, what that actually means for people's out-of-pocket costs and beneficiaries' choices. My concern is around limits there and just creating a more challenging environment for them to afford their own benefits.
Yeah, I'll just add that, especially in the context of an election year, you typically hear about Medicare reform as something that is an accusation, like you're going to cut Medicare, no, you're going to cut Medicare, I'm going to save Medicare. And I think it's rare to see a policy issue where it's just so clear down the line that if you care about having the program be more fiscally sustainable, this is a great way to do that. If you're worried about how this program distorts the rest of the healthcare system, this removes a major distortion, and not only does it not cut benefits for seniors, but it actually lowers their out-of-pocket costs because of the way that those are calculated in the program. So again, just to kind of echo what the secretary said and what was said before, it's a win-win-win, and it's something that just is a huge net benefit to the healthcare system overall.
All right, thanks everybody. I know we've talked a lot about kind of the savings to Medicare, like that big picture idea, but I do want to talk about the potential impacts for patients for a moment, because to my understanding, there is a potential that some patients could see like lower out-of-pocket costs, depending on what their plan looks like. So would anybody like to comment on kind of how this could save patients money?
I'm actually happy to take that. I mean, if you think about a Medicare beneficiary, right? So somebody maybe who's in traditional Medicare who doesn't have a supplemental policy, they're on the hook for 20% of services when they go to see, when they go for any outpatient service, right? So if you're in a situation where overnight the practice that you were going to is an independent practice, all of a sudden now they're acquired by a hospital and they're a hospital outpatient department, the price for that service is going to go up, and you're going to be responsible for part of that incremental increase. So there's that. If you're in a Medicare Advantage plan, there's different cost structures and copay structures depending on where the site of service that you're going to is. So if your choice is now limited to a more expensive site where you're paying a higher copay, you're losing out there. The more Medicare spends on services, the higher the Part B premiums, so you lose out there as well. But in addition to the out-of-pocket cost exposures that not only exist in the Medicare market, but as the former secretary has described, what Medicare does influences what the commercial market does too. So you see these impacts for folks who don't have Medicare as well. But if you have a situation that where a payment structure, and I don't think this is the only thing, right, that is driving very high levels of consolidation, right? But if you're in that kind of environment, also your choices are constrained as a patient. So not only are you looking at increased out-of-pocket costs associated with these distortions, but you also might find yourself in a position where it's harder for you to access the care that you could before, because either your network is more narrow, the sites of services change, or you're in a situation where a practice that you go that you've seen now has to close or sell itself to another system. So there's cascading effects associated with this.
Excellent. I think that's really...
To be clear, I mean, correct me if I'm wrong. I think we wrote this together, so you should definitely correct me if I'm wrong. Even if you have Medigap, you're not like spared from these effects. If the care is more expensive, that plan is more expensive. And so I think this is one of these things that's missed a lot, is everyone says, oh, well, you have this high cost sharing if you're on traditional Medicare and you don't have a lot of supplemental coverage. Oh, but only 5% of enrollees actually are truly enrolled in that kind of plan. Well, no, every type of plan is more expensive if the care you're buying is more expensive. And that, I think, is often ignored.
Excellent. I think that's a really helpful baseline here. I also want to touch on consolidation, because I know, Andrea, you mentioned that, and I know there was some kind of reforms in 2015 of kind of how easy it is for a hospital to kind of convert a physician practice that they buy into a hospital outpatient department. But there is still a lot of outpatient departments that are functioning that way today. So can we talk about kind of what the impact on consolidation of this policy has been in the past and kind of where we're at right now?
Sure, I can take that. So site neutrality, it acknowledges a differential in payments that has existed for a long time, and it's been incremental progress to trying to eliminate that. And simply by evening the playing field between independent physician practices and big hospital systems, you're able to create more of a competitive environment. But going beyond just payment differentials, there's other ways you can apply the principle of site neutrality as well in a way that encourages more innovation, that disrupts that model in the healthcare system. Restrictions on different sites of services, what can be performed in ambulatory surgical centers and other outpatient facilities is an important tool in that as well, and another way to apply that principle. The Medicare trustees mentioned that joint replacement procedures specifically was one example where when you remove different restrictions and allow for services to be performed in other sites of care when innovation warrants it and when the expertise of the doctor goes in that direction for recommendations, you start to see much slower growth in the cost of those services for Medicare. So that's a way to kind of take this principle of equalizing payments, equalizing treatment of different outpatient settings, and applying it more broadly in a way that organically improves the healthcare system.
I think I'll just add like 2 data points onto, I mean, agree obviously with everything Joe said. I think, right, just to kind of put a finer point on sort of how much consolidation there has been in this sense. Right here, we're kind of talking about hospitals buying up physician practices and converting them to a provider-based department or a hospital outpatient department. So back in 2012, it used to be about 35% of chemo administration happened in a hospital outpatient setting. That by 2021 was up to about 52%, right? So we've kind of grown from 35 to 52% of the market. We now have a market where about half of doctors work for a hospital or health system nowadays, right? We've sort of moved pretty strongly in this direction, and there is some work looking at policies that basically increase the differential between payments to physician offices and hospitals for the same services, and finding that that actually has a pretty sizable effect on that sort of vertical consolidation we see. One paper basically attributed about 20% of the hospitals buying up physician practices from 2009 to 2013, so this is a little bit old now, but right, about 20% of that was sort of specifically to this policy. So, on the one hand, don't want to say this is the only thing driving consolidation, but this is actually one of the few policies where we talk about where I think there is a pretty meaningful impact that can be had without something overly complicated.
All right, so I also want to talk about some solutions that have been floated, not to the entire issue, but at least to take some of this on in a piecemeal way. The first part, I know the House passed the Lower Cost, More Transparency Act, that was led by Congresswoman Kathy McMorris Rogers, who heads the Energy and Commerce Committee, and that looked at a very small slice of this issue. So can someone kind of explain what approach that takes and kind of how far-reaching that would be?
I could jump on that as well, because I think you're right that it's a dialable issue. I think so. The Lower Cost, More Transparency Act focuses specifically on drug administration services in those outpatient off-campus facilities that were exempted under the law signed by President Obama. But you can dial that even further. That was about $4 billion over 10 years per CBO's cost estimates to the Medicare program. If you were to remove all the exemptions for off-campus facilities, I believe that's closer to the SITE Act in the Senate. You might mention that later, but CBO had estimated that kind of policy would lead to $40 billion in savings. And if you were to expand that across ambulatory settings and several different routine procedures. The Committee for a Responsible Federal Budget estimated that would save about $280 billion to the Medicare program, $140 billion to patients themselves over 10 years. So when you think of here's savings on the budget to the Medicare program, just think that a 20% at least of that could be going to patients themselves through the cost sharing structure of the program.
Right. I think you skipped ahead of me a little bit, but I don't want to let this go because I think that's part of why we're here talking about this is because the potential cost savings are so high. There's so much bipartisan support, and because patients could save money as well. So I guess are there Andrea, I know you had mentioned some potential pitfalls. What should we be watching for to make sure that the cost savings are really that large in the way that a policy could be structured?
Yeah, and before answering that, to put a little bit of a finer point on, even though it's small, the injectables at a hospital, that's a meaningful difference, especially for cancer patients, right, who go and get a lot of physician-administered drugs. I'm also sort of in the unique position of having my dad, who is undergoing chemo now, have done that at an independent practice, which then got purchased, and watched the incentives change. Now he's in Florida. In Florida now, almost 30% of oncology practices are either owned by or affiliated with private equity, which is a different conversation. But I think to this question, I want to zoom out a little bit and say, while this is definitely a no-brainer policy with the potential to dial up for tremendous savings, there are also other drivers associated with increased prices, with consolidation, right? When you look at how much money, for example, we pay to the Medicare Advantage program, and a lot of the potential policy solutions that have been floated to bring down overpayments there, right? That's another major opportunity for savings in the ballpark of between $83 and $127 billion per year, right? So that's another area to generate savings. But in general, I think in addition to wanting to neutralize prices, you also want to make sure that those prices in and of themselves are not artificially high. And for that, it's important to be tackling some of these other drivers of market power that are distorting the payments writ large, not just trying to correct for two different prices that might both be too high.
Okay, so I also just wanted to open it up and talk about some of the possibilities here, because sometimes when a policy saves a lot of money, that almost works against it because there are big fights over how to use that money. So I guess, can we talk about it all if there's any, you've heard any discourse yet about kind of some of the possibilities for how to leverage these savings?
And I think politically, some of it is just the hospitals want the money back, right? I think the sort of two main objections you'll hear from the hospitals will normally throw out, right? There's sort of two main objections. One is, oh, but we treat sicker patients than the independent physician offices. That one, we now have pretty good evidence from MedPAC that, one, the patients they treat are actually pretty similar, maybe slightly marginally sicker at the hospital. But again, we're talking about a bucket of services here that are, so we're talking about basically imaging, drug administration, like chemo administration, and just an office visit. These are services that are lower complexity where even just sort of the hospital's own numbers show that they don't actually charge any more for a sicker patient in those. So there are no cost differences by the sort of sickness of the patient in those situations. So that one seems to be a bit of a red herring. And then they'll sort of throw out the fundamentally, it's if you take $1 away from us, everything will die and all your hospitals will disappear, right? They'll focus specifically on rural hospitals, but to some degree, this is the standard. The pharma companies will use it. Anyone will sort of use that 1 cent less, and we're right on the brink, and then we're all going to go under, right? That is where I do think you end up in some situation where you could use some of this money to shore up the sort of rural hospital side of the coin. That is plausible, right? There's kind of the physician versus hospital version of this world here, right? From a sort of where you're going to use the money perspective. There's actually, I think, sort of been interesting interest from the Doc Caucus in Congress on this issue, where there's a lot of money on sort of Medicare physician payments not growing or keeping up with inflation, where that some of that money might be used in that way. So you're also right, kind of both sides tamping down the incentive for hospitals to, or sort of the incentive to stay independent as a physician by also throwing more money at physicians. But I think the secretary's also brought up earlier. At the end of the day, it's kind of a little bit dependent on what the sort of big package is, and that is certainly the most likely. Is that this is an offset for someone, right? Never let an offset go to waste is sort of the standard motto. You're not gonna, this is just because it's a good policy that helps is not, you're not gonna like throw away those savings. But using it for things you would have already done seems to be at least a useful accord.
You could also go a little bit further and use it for things you wish the program looked like, right? So thinking about what Secretary Sebelius has shared really resonated, right? It's hard when you start by even inferring that benefits are going to be cut. We know that one of the things that is hard for a lot of beneficiaries on Medicare, right, especially in traditional Medicare, is there's no out-of-pocket max, right? This type of the savings from some of the types of things that we've described today could help finance something like that. Traditional Medicare doesn't cover dental, vision, hearing. It could, right? And you need money to pay for that. So looking at savings is a key opportunity for that. So I think messaging about what are you going to do with that savings is really important. But also thinking about that political pushback piece, I also appreciated the conversation about, especially in rural hospitals, right? There are much bigger problems than payment distortions. It's very hard, as former Secretary Sebelius shared, to recruit and retain physicians there. It's fascinating, right, to spend some time in those places where hospitals have closed and to talk to people about what it is they wish they had, right, what they could sort of right-size, and also to see examples, right, where a parent, very large corporation comes, acquires a rural hospital with promises to make it more efficient, drains it, and closes it, right, and pulls the rug from underneath that rural community. That happens not unoften, right, and that's an issue too. So there's a lot of different things to solve for, and I think this becomes a convenient punching bag to say, oh no, we don't want this because it's just going to make things harder for us, when really, like, that's not the driver.
Okay. If you don't mind.
Go ahead.
This has become sort of, I think everyone on the stage here is particularly the rural hospital piece of this over and over and over again. I just really want to emphasize this point. I have a lot of sympathy for the challenges that particularly acute care hospitals face in many parts of the country. Your payer mix is not so good. Your population might be shrinking. You live in a different financial world than the Mayo Clinic and Hopkins and the cancer centers and all sorts of things. The idea that in order to solve that, you should overpay all of the hospitals in America is so backwards. It's like we've completely lost the point. If you accrue savings and you think that there is a genuine argument that there are hospitals that will close without intervention, and you think that those are worthy of subsidies or payments or whatever you want to call them, then explicitly give them money. Brian mentioned it earlier. We have lots of programs that do this in various ways. DISH, critical access hospitals. We have, I think, Medicare dependent hospitals. We have all sorts of programs that either could be expanded, you could create new programs, you could literally send a check to them. But the key is that it's so much more efficient in terms of the use of money, because you're just targeting the money at the hospitals that you're worried about. You're not targeting the money to every single hospital and then hoping that the spillover is that rural hospital in northern Arkansas or whatever can manage to stay open because of this.
And particularly because the rural patients also have to pay more for that. So it's like that's the group you want to be helping the most.
And it's probably not even the hospital. Like the rural, hospitals with bad payer mixes and declining populations are probably not the ones that are really driving all of the purchasing of physicians' offices and so on. That's probably the bigger hospitals to begin with. And so the people that sort of could hurt more absent the kind of, policy design choices that Lauren was mentioning are the hospitals that are using this more to their advantage in the status quo. And so I just really don't think that argument holds a ton of water.
Yeah, that's a great dialogue there. And I really just can't emphasize enough how often we hear this. I am on the Hill asking senators about it all the time. And if you look at the Senate Finance Committee, which regulates Medicare payments on this issue, you have members from Iowa, Idaho, South Dakota, Wyoming. Like, it really is the number one thing that I hear from lawmakers when I ask them.
And when you
this.
look at the way that hospitals operate, I mean, it's a compelling argument. The cost structures of those hospitals are wildly different than the hospitals that have lots of commercial pay patients, are the big academic medical centers, have big donation funds. Right? Their cost structures are much, much higher than these lower margin, or often lower margin, much, much lower cost hospitals. So the data are clear. They are living in a different financial reality. But the question is, should that justify maintaining the status quo in terms of this policy and other policies? And I think the answer for that is no.
And if you take a step back, just like if you were designing the policy from scratch here, that no one would think that is a good idea to just throw a bunch of money at the big publicly traded hospitals, the PE-owned hospitals who are starting up film studios now, right? You're going to be that this seems like not a good way to be throwing money in order to hope that, you know, maybe 1% of it flows through to the hospitals who are actually in need.
Okay, I do want to move on to an audience question that we got about, we've been talking a lot about Medicare and the potential of this policy for Medicare, but obviously there's some conversations as well about what kind of implications this could have for the commercial market. And as we know, the potential savings to the healthcare system could be, exponentially larger if we're looking at commercial reform as well. So would anybody just kind of like to talk about, how big this could get if this could potentially spread, either through like a trickle-down effect from reforms of Medicare or from some additional kind of legislation or regulation in this area?
Yeah, so I mean, Medicare for so many private payers and commercial insurance plans is the starting point for their negotiations with providers. So simply removing this disparity, I think, would have a lot of effects kind of trickling out to the rest of the healthcare sector. And of course, as we've mentioned before, site neutrality and site of service differentials aren't the only policy choice that leads to consolidation, that leads to other distortions. So you could talk about a whole menu of options, but I think that simply getting rid of this one bad distortion and making sure that government policy is not making things worse and allowing for these changes in government will have an impact in the private market and all the other government programs that take Medicare as a reference point as well. I think there's been you take the savings numbers in Medicare of hundreds of billions of dollars and you can multiply that by another factor in terms of savings and government savings.
I'll only just highlight it, right? I think it's true. We have plenty of evidence that when you lower Medicare payments, that has some spillovers to lowering commercial payments as well. But like the main lever here, still like the policy lever, is Medicare, right? Medicare just has this policy to pay more for the exact same service. In the commercial market, at least, there are private actors who are negotiating. So, but Medicare, right, there is nothing, there's nothing that can be fixed without the government intervening and changing the policy.
Excellent. And I want to take another audience question as well about kind of how we could anticipate hospitals' behavior changing if even like a small kind of law passes on this issue. Do we know how hospitals could react? Maybe not. You might have stumped a very smart panel, everyone.
I mean, certainly at some point you would, there is less incentive to keep buying up practices, right? The policies we are talking about right now are still pretty small bore, right? The version of the policy that sort of made it the farthest on the hill last year was just for drug administration, just at off-campus hospital outpatient departments, whereas yes, there is a lot of money at the sort of off-campus, which is sort of, hospital slaps its name on a physician's office. But there is also a lot of money on more money on the hospital's main campus here, and sort of none of the policies have really kind of gotten to that side of the coin, where I think you might start seeing more of this difference. Certainly, I think you'd see some effect nonetheless, like there's still some effect for those services, for an oncology practice or for a rheumatology practice where the sort of drug administration matters more, where maybe you see some level of effect there. But I think to see the sort of like big, at least stop digging the hole deeper and pause at least some level of added competition from independent practices. I think we really need to kind of scale up to the sort of bigger versions of this policy.
This is perhaps not exactly the question, but maybe my biggest source of uncertainty about this kind of policy is there are lots of things that reward hospitals and other entities for consolidating. This is one of those things, and it's one of the most explicit things that you can change via policy. However, it is an open question as to how strong this is compared to all of the other things that push in the direction of consolidating. So, for example, if we're talking about drug administration, lots of hospitals get 340B pricing, and so they have an incentive to buy up docs that administer lots of expensive medications. Well, how powerful is this policy in a world where that policy still exists? And I know we have some evidence that we can pull from, but we don't know. And so I think in terms of open questions and how hospitals respond, that's one for me. Is this is one thing pushing in the direction of consolidation, and it's an open question of how big of an effect it really is.
Yeah, I think that's a great question, especially when with the potential dialing effect, like how, yeah, I think there are just so many variables here. It'll be interesting to see how that plays out. So I also want to bring up one other audience question we had about how this fits in with price transparency regulations. I know that was a big push that started with the Trump administration. The Biden administration has kind of continued those efforts. Like, is there a relationship here with the kind of story that Secretary Azar brought up about, you know, not being able to get a price for a product, or are these kind of separate issues in your minds?
I think the Secretary's story really illustrates that all of these changes in pricing and corporate structure that go on behind the scenes are not things that patients themselves pick and may not even be aware of. So coupling those two things, price transparency with site neutrality, I think would do a lot just to create a more competitive marketplace. When you're talking about other restrictions on hospitals being built at the state level with certificate of need laws, bans on things like physician-owned hospitals and other non-hospital models, which I think the healthcare system is really moving in that direction, where the hospital is not as much of the central delivery vehicle for healthcare anymore. If you have that more widespread availability of information for consumers, for payers, for third parties who might want to be informing these patients, that's something that more organically and just over the long run creates a more sustainable ability to save money and have downward pressure on prices, I think.
Yeah, I think especially for the commercial market too. I mean, it's hard to construct a benefits package that is really looking out for the best interests of your enrollees and is paying the best reimbursement that you can when you don't have a sense of how distorted the market is. So I think even just like if you're thinking about this from a values perspective, right, just out of fairness, it's helpful to see how much is being charged for the same service at different sites. So I mean, and just how much is being charged generally. So former Secretary Azar's experience is a very common experience. Probably all of us, everybody in this room probably has had that experience. It is incredibly frustrating and just fundamentally unfair that you don't know how much something's going to cost. So I think in and of itself, there's value in transparency.
You can do each by themselves, but conceptually, the whole point is you have to let a lower cost place somehow gain some market share by being lower cost. Right now, Medicare is interrupting that. The fact that you don't know the price is interrupting that. Anything that is allowing those lower cost places to actually accrue market share like they do in other markets is working in conceptually the same direction.
Excellent. So another audience question we had was about the Medicare Advantage space. Obviously, that's a growing share of Medicare enrollees are in these plans. Can they do anything to move toward this policy on their own, or would there have to be some action on that from policymakers before they would be able to do that? Do we know?
Well, I think as Lauren mentioned, there's more flexibility to negotiate contracts. Many private plans do use Medicare as a starting point, but at least theoretically, they should be able to discern where there's more value to be gained from a marginal change in contracting at least. There can be other non-pricing mechanisms for making sure that the providers are contracting with are high quality and just having other controls on quality and coordination of care. So there's a lot of different tools in the toolbox. Pricing is a very straightforward one, and government policy can directly impact it in the case of traditional Medicare. But I think we should hope and expect that actors in the private sector, to the extent they are able, should be trying to drive more value in the system for their own enrollees, and competitive pressure can do a lot to help give them the incentive and the ability to do that as well.
Yeah, I mean, Medicare Advantage is just a little tougher because everything follows Medicare, traditional Medicare, very closely there, and because you're also paying them traditional Medicare prices for those services rather than 2 or 3 times that a commercial insurer pays. It's unclear how much a Medicare Advantage insurer could really change that. There's also rules on sort of the benefits you need to cover there, but also even if they could. Right, if you did this policy in traditional Medicare, that actually saves money on the Medicare Advantage side of the coin as well, because Medicare Advantage plans are paid based on how much traditional Medicare costs. So it effectively not only would sort of mechanically flow through, but it would very clearly flow through to Medicare Advantage costs. So there are savings on that end from doing the kind of core traditional Medicare policy here.
And there are, I guess we could mention, it's a slightly different policy, but there are some concerns by, at least in the commercial market, insurers, when you push them and say, like, why aren't you doing more on this? They'll often turn around. Well, I have varying levels of sympathy for them. They'll often say, well, look, there are a lot of cases where it's very difficult for us to tell whether something is or isn't on a campus because of the way that billing works. And so there are policies that have been proposed on the Hill where they would try to basically, I think of them kind of buttressing this site neutral idea, make it clearer, make it easier for insurers to identify where service is being done, and that makes it easier for them to push back on the stuff that's off campus and so on.
Excellent. So I want to return briefly to kind of the issue of rural hospitals. And so imagine, there's a staffer, they really want to protect the rural hospitals in their district, but are kind of interested in this idea of site neutral reform. Are there ways besides like Ben's mailing direct checks to rural hospitals from the savings where policymakers could potentially protect rural hospitals while still keeping the integrity and the spirit of kind of the bigger picture here on site neutral?
I'll offer one more, since you didn't like my first idea, I'll offer one more global idea that applies not just to rural, but helps them clearly, which is that, there's this political question of how do you use savings from this? I think crazy ideas like, lowering debts and deficits are a cool idea, but, since nobody else likes that, one idea is to say, look, there's this fight about physician payments in Medicare. And physicians have been frustrated for a long time that they don't have the kind of automatic growth and they feel like they've been shortchanged over time. Well, one thing you could do is you could say, we're going to use some of the savings from this to increase and put that fee schedule on more of a sort of long-term reasonable trajectory. What that does is it also buttresses against revenues falling very much at hospitals, because you're saying, look, for all of these things that, all these imaging and drug administration services and so on that you're delivering, we're going to pay you the fee schedule now, but we're increasing that fee schedule and putting it on a more sort of predictable long-run growth rate. That helps lessen the blow across all hospitals. It's not rural specific, but it's at least a baseline idea if you think that is a good use for the money.
And I think these are they're two interrelated, but they're different questions. I mean, there are things that you could do in any potential site neutral legislation that could carve out and make exemptions for particular types of hospitals. But I don't want to convey, right, that the rural hospital many rural hospitals, right, are in a very tenuous situation. That is a real issue. Spent time in those places. I've been in places that have had their hospitals close, reopen, where there are like prayer vigils every week, right, in the parking lot, hoping that the hospitals will reopen. And there, I think you're going to need some pretty creative solutions to actually figure out what a sustainable financial schema looks like in different rural communities. And that you could be really creative with solutions there. Maybe that looks like a public utility. I mean, there's all sorts of ways to think about that. But I really think that has to start with a fundamental reimagining of what we want out of rural healthcare, what we expect, and starting from, what is the system we actually most want, and then how do we finance that? Like maybe break out of just thinking about how you tinker with different, financing legislation that is designed for the whole system, and instead start to ask the question about how you can create something that's specifically tailored to rural hospitals.
Yeah, I think the systemic approach to how you're thinking about rural care in general is definitely more helpful than saying, okay, we'll do this for some hospitals, we'll carve out the rural hospitals, particularly because, again, you don't want the higher cost sharing or the continued consolidation to fall on the rural areas. So if I can do an anti-endorsement, it would be for something that's just a simple carve out, and trying to think more about how do we support rural healthcare with all these other levers we have through policy.
Yeah. I think you need to define rural in a strong way if you're getting any of these policies, because some quote unquote rural hospitals are basically in a wealthy suburb. So there is a little bit of, sorry, because that was more a preface of the next policy is, right, there's nothing stopping you from varying a Medicare payment by rurality. There are plenty of ambulance fee schedules, for instance, give a bump up for if you were in a rural zip code or a super rural zip code. There's nothing stopping you from having slightly higher inpatient payment, sort of like the inpatient Medicare payments. Or, again, going back to the physician side, sort of adding an incentive for doctors to go work in rural areas by having higher Medicare payments to doctors in rural areas. And again, you can define rurality. I think there's an important discussion there. But again, sort of in the off-the-shelf measures here, the disproportionate share hospital payments are probably the kind of like most natural off the share. A lot of states have sort of uncompensated care funds that probably, so you could throw money at states to kind of help allocate it towards the hospitals they see best fit also. But again, right, because probably 1% or less of the savings of this policy are coming from rural hospitals, you can still keep most of the savings, whether towards deficits or debt or your sort of favorite new program, right? The sort of money that needs to kind of offset those hospitals and keep them whole actually is like a pretty tiny portion of this.
Yeah, I think that's the key. To make them whole relative to their current status quo is really cheap relative to what you could generate in savings. The broader question, it goes so far beyond site neutral. I think that emphasizes this point that like the site neutral thing is just a drop in the bucket in terms of how do you address rural healthcare. And I think the flip side of that is it makes it a very uncompelling argument against this particular policy, but it may be a compelling argument for other types of policies that help them.
All right, everybody. Well, thanks so much to AEI, to Brookings, to CAP, and Paragon for coming up and having the discussion. And thanks for all the audience members that contributed questions. Really helps make our events better and make sure we're addressing like what you're really curious about. And again, thanks to Arnold Ventures for making this event possible. I hear there might be some light refreshments down in the first floor until around 1 p.m. So feel free to head down there and mingle and network and just meet some of your fellow health policy wonks who are interested in site neutral payments. So thanks so much for coming, everybody.